Hello and good afternoon. This is Dr. Ash from London. I hope you guys are having a very good day today and enjoying your weekend. This is Sunday, it's a midday, and we are here having a very bright sunny weather in the United Kingdom. So today my topic is emergency medicine. Today we are starting a series of lectures on EM. This is my first lecture on it, that what is emergency medicine. In future we will discuss so many other aspects, financial aspects, freedom, flexibility, and all other aspects. So today, let's talk about what is emergency medicine and what is emergency physician, what they can do. So, without wasting my time, let me tell you, emergency physician is the only physician in the whole hospital who can relocate the ankle. There's no other physician who can do that other than orthopedic team. So, either you are the specialist or ED physician. Only those can do this job. Similarly, the ED consultant is the only consultant other than the cardiology can do the cardioversions. ED physician is the only physician who can get 6 weeks old child, newborn child resuscitated other than the pediatrics. Emergency physician is the only physician who can relocate ankles, hip, shoulder, elbows, and the other one are the orthopedics doctor. Similarly, ED physician is the only physician who can put the chest drain in other than the cardiothoracics or surgeons. They are the only physicians who can do the pericardiocentesis. They're only physicians who can do ultrasounds other than the ultrasonologists. So it's a cluster, it's a mixture of kind of combination of all other specialty who can deal acutely patients. So this is a physician who can do almost everything, anything, and he has a potential to expand his horizon in many directions. Emergency physician can later on, if he decides to become an acute medicine consultant, he can become acute medicine consultant. Emergency medicine physician, if he wants to be an intensivist, he can be an intensivist. If he decides to become an anesthetist and emergency physician, he can do that. Emergency physician, if he decides to become a geriatrician, he can become a geriatrician. So, pediatrician, peds emergency physician. So it's a vast exposure he has. Interventional radiology, putting a chest drain, ultrasound guided, putting a chest drain, open chest drain, getting aorta scan, all those things. If the emergency physician can do that, which is really life-saving skills. That's all about the emergency physician. What is this specialty? So, to understand emergency medicine, I think we need to see the model, how the system is working in first world country and how the system is working in third world country. In third world country, still emergency medicine is not established, and there is a specialty based input. So, if a patient has got the surgical problem, they go to surgeons, come and see orthopedics. The orthopedics consultants can come and see the patient. But who is going to say the safe transfer of the patient? There's no one who can actually tell how you transfer the patient. There's no one actually in the whole specialty who can actually clear the neck, cervical spine of the patient. There's no one actually who can protect the neck. So, ED consultants, ED physicians are trained to do intubations, chest drains, chest tubes, relocations, and all the medical problems. They can actually manage it very nicely. So this is the bit of background. Now, I said that this specialty is the mother of all specialty. It's a very strong statement, isn't it? In my title, as I can say that emergency medicine is the specialty's mother. It's the mother. Why? Because the role of mother is actually to keep everyone comfortable, isn't it? In the home. If the mother is at home, everyone is at comfort. Similarly, if you have a trained emergency physician, the whole hospital is at comfort. Now, I said this statement in front of 1,000 people in Pakistan when I was addressing the EM symposium, and surprisingly, no one actually opposed that, because what I said that, is there any cardiothoracic surgeon sitting in this department, in this symposium? Is there any orthopedic surgeon? Is there a neurosurgeon? They said, yes, we are here. I said, okay, if you get a patient with the neck spine injury with neurovascular damage or without neurovascular damage? Who you prefer most? Of course, they said the patient who has C spine fracture but intact spinal cord, no neurovascular damage. So I said, how is it going to happen? Because most of the time, if the ED consultant is not trained, ED physician is not trained, the cervical spine injury patients, they get a spinal cord injury. So we have seen that so many times, isn't it? Similarly, the same question I asked to orthopedic consultant, if you have a patient with a fractured shaft of the femur, with a neurovascular damage or without neurovascular damage, who would you prefer? Of course, he said for the better outcome, because even if the neurovascular damage, if he's going to operate, the outcome will not be great and he cannot take the credit, isn't it? Because the neurovascular damage is there. Even if he's fixing the bone, it doesn't make much difference. So I said, who is going to protect that neurovascular damage? That has to be emergency physician. They are the one who apply the Thomas splint. They are the one who who do the fascia iliaca block. So similarly, you can go on and on and on. There are every other specialty can be in a great comfort if the anesthetist knows that there is a shoulder dislocation downstairs and someone can do the safe sedation. So they will be at comfort. So basically, from one specialty to whole specialty all across the hospital, you are the one who can actually keep them comfortable. Ask an orthopedic physician, orthopedic surgeon, how frequently you would like to go to A&E to put the shoulder in. Would you like to do that? Actually, I have worked as an orthopedic trainee in Pakistan. No one wants to go to A&E because of this small stuff. They all want to learn a specialized stuff. Knee replacements, hip replacements, they want to do a shoulders, they want to do hands-on operation theater skills. So this way, if an ED consultant is trained, they don't need to come to the hospital, they don't need to come to A&E, especially if you are having airway issue and that the patient is going to die and anesthetist is not straight away available and the ED consultant is trained, they can actually save time and they can put the tube in. So it's a very specialized kind of field with a very broad spectrum where the consultant can intubate, can do the cardioversion, can put the chest drain. Now, just imagine a foreign body in the eye. Only ED consultant can remove or an ophthalmologist can remove. Only ED physician can remove or ophthalmologist can remove. Isn't that fascinating? That putting a needle in the cornea, how many of you can actually do that? So similarly goes with the epistaxis. Quinsy, either ED consultant can drain or manage properly, or the ENT physician or consultant can manage properly. Foreign bodies from the vagina removal, either we can take it out or the gynecologist. No one else can actually go near that, or a surgeon who is specialized in it, they will do that. So this is a broad spectrum about emergency medicine. That's why I say this is a mother of all specialty. ED consultants are trained to do anything, everything. They have a scope, they have a huge potential to lead. In near future, I will be sharing the other aspects of emergency medicine, that what kind of financial aspects are, private practice if it is not there, is it worth becoming an emergency consultant, and what else you can do alongside with the ED physician job. I hope you guys like this video. Please do comment, share, and stay connected. The next lecture will be very soon. Thank you very much, Dr. Ash from London.